Hello. Thank you for joining me on this talk about the acute effects of heat therapy on vascular function in COVID-19 survivors. Let's start off by talking a little bit about what exactly COVID-19 is. It's a severe acute respiratory syndrome caused by a coronavirus with approximately 30.9 million cases in the United States alone. Approximately 30% of survivors suffer from long-term effects of COVID-19. Pre-existing conditions such as hypertension, diabetes, and cardiovascular disease, as well as age, can all predispose someone to not only become a more severe case, but also experience these lasting symptoms. Among the many long-term effects of COVID-19, the two that we chose to focus on primarily are fatigue and vascular dysfunction. Vascular dysfunction actually precedes cardiovascular disease, making it all the more important to look at within this population. This is data provided by the Ratchford Group, who did a study on young, otherwise healthy COVID-19 survivors and their vascular function. They chose to measure FMD, or flow-mediated dilation, which is a measure of endothelial and vascular function. We see that that has actually decreased from our control group to our experimental group. This is true across our male and female groups here, and it's actually decreased all the way to the level of heart failure, which is really interesting to explore within this clinical population. So why are we choosing to use heat? Heat is actually a therapeutic approach with potentially similar results as exercise. Exercise has long been held as the gold standard of physical rehabilitation, but with the conditions being experienced by this population, it can make exercise rehabilitation a bit harder for them, whereas heat therapy offers a viable and passive approach that can be more easily adhered to by this population. The application of heat to affected areas improves circulation and can cause vasodilation as well as increase in vascular function. Chronic heat is actually associated with reduced cardiovascular related morbidity and mortality. The aim of this study was to determine the FMD response of the brachial artery after the application of acute heat exposure, leading to a better understanding of the effect of heat exposure on endothelial function. The hypothesis of the study was that the FMD response of the brachial artery would be increased or enhanced following acute heat exposure. To start off, we performed a heat titration session prior to our protocol, and our participant was placed in a lower body water-perfused suit in order to apply heat to the lower limbs, where skin sensors were placed on the TA, calf, quadricep, and hamstring skin sites, and the therapeutic temperature was defined as that at which the skin sites averaged to 38 degrees Celsius. This happened to be 40.5 degrees Celsius for this particular participant. Normal skin temperature is around 33 degrees Celsius, so we are seeing that significant increase of 5 degrees Celsius. Our protocol itself started off with preheat FMD measurements. Then we had our application of acute heat for 40 minutes. And at the 60-minute time point, we collected our post-heat FMD measurements. Our flow-mediated dilation, or FMD measurements, were collected as follows. We placed an inflatable cuff on the forearm, and our ultrasound probe was placed on the brachial artery. The artery was scanned for 2 minutes to collect baseline measurements. At this time, the artery was at resting diameter. The cuff was then inflated, and then the artery was occluded for 5 minutes, during which we collected measurements and induced ischemia within the artery, and so we see that decrease in vessel diameter. Then the cuff was released, and we see that increase in flow drastically, which is referred to as reactive hyperemia, which we caught for 4 minutes. During this time, shear stress is increased because we do see that severe increase in flow, and our NO release is increased as well. NO is nitric oxide, which is a vasoprotective molecule. It keeps the vessel healthy, so you definitely want to see a good NO response. During the reactive hyperemia stage, our vessel diameter increases in order to accommodate that increase in blood flow. Imaging the brachial artery, we have a sample ultrasound scan here. We have our ultrasound image on the top as well as our Doppler spectrum on the bottom. So in an artery, because it is leading away from the heart, we want our forward flow, which is antegrade flow, and we don't really want retrograde flow, which is reverse flow. We don't want flow going back to the heart. That's depicted here with color flow. Our orange/red is antegrade flow, and blue would be depicting retrograde flow. On our Doppler spectrum, we see our antegrade flow with this big spike above the axis, and then this small spike below the axis is our retrograde flow. So looking at that ratio between the two, we can definitely see that there is more antegrade flow in relation to retrograde flow. This is a screen capture from one of our studies. We have our mean diameter on the top and our shear stress, or shear rate on the bottom. These curves were captured within our cardiovascular suite, which is a automatic edge detection software. And in this, we were collecting various measurements. So we see our baseline collected for 2 minutes, our occlusion collected for 5 minutes, and our recovery period collected for 4 minutes. We also look at our average baseline diameter as well as our peak diameter. The peak diameter is the diameter that is reached at the highest point after our cuff release. The difference between the baseline diameter and our peak diameter is the percent change, which is our FMD percentage that we are measuring. We also look at the time to peak, which is the time that it takes to reach that peak diameter after our cuff release, which comes from this point to our peak diameter point. We are also looking at our reactive hyperemia, or shear rate area under the curve, which is another measure that we are depicting in our results. For our participant characteristics, there's a lot going on here, so just a couple things to point out. A 73-year-old female with a BMI of 25.8, body fat percentage of 43.8%, blood pressure 112/57, pretty healthy for a person that age, glucose level 89 within normal range. But we do see that our C-reactive protein, which is an inflammatory marker, is increased. Normal range is around 0.2 to 0.9, which 1.5 is significantly increased from our normal range within this participant. They were diagnosed spring 2020, so it's been about a year since their diagnosis, and their hospitalization lasted 7 days. Again, the titration temperature was 40.5 degrees Celsius. Medications, they were on a beta blocker, Restasis for dry eyes, cyclobenzaprine for muscle spasms, and Breo for exertional asthma. Diving right into the results, we are seeing that FMD is decreasing with acute heat. Now, it is decreasing from our preheat to our post-heat conditions, but only slightly by about 0.7%, so not particularly significant. It stays pretty much the same within our pre to post heat conditions. We also see that our baseline diameter has stayed pretty much the same, meaning that our imaging location is consistent across our pre and post heat conditions. We do see that our reactive hyperemia is increasing. So again, that blood flow, that increase in blood flow that we're catching after our cuff release has increased from pre to post heat conditions. But when it's normalized, our FMD is normalized to our reactive hyperemia, we do see that, again, that decrease in our normalized FMD. However, it is also taking longer for us to reach our peak diameter, as we can see from our time to peak curve here. It is taking longer to reach that peak diameter after cuff release when comparing our pre to post heat conditions. We are also seeing that retrograde flow is increasing with acute heat. Our antegrade flow and retrograde flow are both increasing, but retrograde is increasing a lot more than our antegrade is. We calculated the oscillatory shear index, which is the proportion of total flow that is retrograde flow, and we're seeing that significant increase in our pre to post heat conditions here. In conclusion, in this participant, acute heat stress did reduce FMD, albeit slightly. However, acute exercise has also been shown to reduce FMD transiently by causing inflammation. So this is data provided by a Dawson Group review, and they looked at acute exercise in various kinds of conditions and groups and kind of put together this data to show that FMD is reduced transiently, but however, after chronic conditions does appear to increase on average. So in this study, they actually did FMD 24 to 48 hours after the acute heat session, and we're seeing those increases in FMD response. Heat could have caused a similar inflammation, causing that reduction in FMD, and it could also be a function of the time point that was picked within this participant. Further studies are definitely required to determine whether or not heat therapy follows the same upward trend as exercise therapy. And the Oxygen and Muscle Metabolism Lab is actually conducting a chronic intervention study ourselves with the application of heat and comparison of brachial artery parameters across time points. Funding and acknowledgements. This work was funded by the IELTS MIDI grant and the NIH National Heart, Lung, and Blood Institute, and this project would not have been possible without the help of members of the O2M lab within IELTS at UMass Amherst. Thank you for joining me for this presentation. Please do not hesitate to reach out with any questions.